Kees, thank you very much indeed for speaking on Cancer TV. Tell me who you are and where you work and what you're doing in this excellent meeting, apart from running it.
Right. My name is Kees Punt. I'm a medical oncologist, and I'm a professor of medical oncology at the University Hospital in Nijmegan, in the Netherlands. And I'm also the chairman of the Dutch Colorectal Cancer Group.
And that's the group that's organized this meeting here in Nice?
Right. I mean, the Dutch Colorectal Cancer Group first, I think, became famous for the TME study, which proved that preoperative radiation was of benefit in patients with rectal cancer. After that, I took over as a chairman, and I built it as a truly multidisciplinary group. And we have now representatives from surgery, medical oncology, radiotherapy, radiology, pathology, genetics, and gastroenterology. And our main goal is to initiate clinical trials in colorectal cancer and thereby increasing the quality of diagnosis and treatment.
You don't physically do the trials yourself, or you do?
I do. I'm the principal investigator of the CAIRO studies in the metastatic colorectal cancer.
And what are they about?
CAIRO studies, the first CAIRO study was on the sequential versus the combination treatment. And to everybody's surprise, it was shown that upfront combination treatment was not superior to sequential treatment, which we published in The Lancet in 2007. And the second CAIRO study, CAIRO 2, was on standard treatment, oxaliplatin, capecitabine, bevacizumab, plus or minus cetuximab. And in that study, it was shown that the addition of cetuximab was detrimental in terms of progression-free survival. And we published that last year in the New England Journal of Medicine.
Big impact stuff you're
doing.
Yes. Small country, but big impact.
Yeah.
So the title of this meeting here in Nice is the European Multidisciplinary Cancer Congress. Are you going European?
Well, we had our meeting in the time of the TME study, which was a local meeting in the Netherlands, but which attracted more and more foreign participants. So then when we were truly a multidisciplinary group, we decided to go more abroad and European. So this time we have the third meeting, and the first two meetings were held in Berlin in collaboration with the German and Scandinavian groups. And this time we had a collaboration with the French, Italian and Spanish groups. So we to attract more participants from outside the Netherlands. And with our attendance is increasing, and we have now close to 700 participants. So we do not want to get that large because we truly want to have the multidisciplinary interaction. Sure. So we do not have parallel sessions so that each individual from the respective disciplines can get involved in the developments of other disciplines.
But you do have some interesting debates too. I mean, you structured debates right through the whole program, which was most interesting.
Right. There's still a lot of controversial issues, and I think these are best highlighted when the extremes are being presented by experts in the field.
Yeah, I couldn't agree more. And hot topics coming up at this meeting, or expectations?
I think we had a very nice update of the SCRIP study. Is a Dutch study of adjuvant therapy in rectal cancer, observation versus capecitabine, and it's still an underpowered study, but so far the data show that there is really no advantage for adjuvant chemotherapy in rectal cancer, while still...
This is totally resected or irradiated?
Totally resected and irradiated, and a lot of people over the world still consider that standard treatment, but this study shows there's at least some doubt about it.
Right, that's good. And any other hot topics?
I think the rectal sphincter saving techniques are certainly worthwhile. We had an interesting talk this morning about genomic profiling. So I think there's a lot of going on also in translational research in colorectal cancer.
And we've got the first, I suppose, therapy indication based on a mutated oncogene, the RAS story in colorectal cancer. But that's just the beginning, because there are other genes, and you don't always get a 100% response in a wild-type RAS patient's cancer if you give a targeted therapy.
Sure. I mean, we know now for sure that in KRAS mutated patients, we should not administer anti-EGFR treatment. Yeah. But in the wild-type patients, there are responses, but absolutely not in the majority of patients, as you mentioned. So we have to learn more about other predictive factors. And Sabine Teschper from Leuven will, in this meeting, update the current status of more markers that will help us to better select the patient population within the KRAS wild-type population.
Right. What are your front runners?
Sorry,
biomarkers? Which are your favorite biomarkers? Would you?
Oh, I have a lot of promising markers, PIK3A, P10, but it's difficult. The numbers are low. The techniques are not always comparable between studies. So I think we should really aim to a more uniform way in testing these markers, and ideally in a prospective manner. But that will be, of course, less feasible, because if you have a phase 3 trial based on a prospective based on your marker settings, it's a lot of difficult logistics. But I think that is the way to really validate the true issue of the markers.
Kees, congratulations on another excellent meeting in Nice. Really enjoying it, and thank you for speaking to us.
My pleasure. Thank you.